Thank you, Dr. Aisha. It's a pleasure to invite the first speaker of this session. Session is about combined procedure in special situations. So very special person coming up, Dr. Usama. He is our clinical secretary of Pakistan Society of Metabolic and Bariatric Surgery and working at Aga Khan University Hospital as assistant professor. So welcome, Usama.
Can I have a presentation, please? Thank you so much for inviting me, IBcast and PSMPS. So I'm going to talk about one of my favorite topics, that is combined procedure hiatus hernia repair in case of a bariatric patient. So I don't have anything to disclose. So in this presentation, I have tried my best to synthesize some recent evidence and some guidelines into briefly into some suggestions or recommendations so as to follow in case a hiatus hernia is discovered in case of a bariatric patient. So let's start with the definition. So I'm sure that all of you are aware of the anatomical classification of hiatus hernia, type 1 to type 4. But there is also other types of classification, especially the endoscopic classification of a hiatus hernia, which we also need to be aware of, and it's coming later. So, first of all, executive recommendations. So I have tried to formally sort of organize my presentation, some of the executive recommendations, and well, this is one of the recommendations to try cycling at a sea view road in Karachi. And so these recommendations are based on the IFSO, SAGES, ASMBS, and International Society of Disease of the Esophagus. And these recommendations start with the clinical screening and end at the post-operative surveillance. So these are this is the outline of my presentation. So let's start the screening and diagnosis. How do you suspect a hiatus hernia in a bariatric patient? So for the trainees, there are only two typical symptoms of reflux. And then there are some atypical symptoms of reflux as well. So the typical symptoms of reflux include heartburn and regurgitation. And then there are some atypical symptoms. So a patient who is presenting with any of these symptoms, you can always suspect a hiatus hernia to be present in these patients. And then you need further workup. So the first line workup that we do, these are the various symptom scores which have already been discussed. So the first line investigation in case you're suspecting a hiatus hernia or if a patient has significant reflux, then the first line is upper GI endoscopy. So according to the 2025 IFSO report, at least 2/3 of the patients have been found to have positive findings during endoscopy. 1/3 of the patients needed treatment, and 1/4 of the patient we had to change the bariatric procedure which was being offered. So it is an extremely valuable investigation. However, in our setup, it's difficult to perform for all the patients. So, but the bare minimum criteria is if you're suspecting a patient to have any degree of reflux or upper GI symptoms, then we should definitely go ahead and do this one. So this is the Hill classification. Basically, it tells us how snugly the gastroesophageal junction and the angle of phase fits around the esophagus on retroflex view, and it starts from grade 1 to grade 4. Then there is a degree of esophagitis which may be present, Los Angeles classification, then Barrett esophagus may be present, short segment or long segment, and the patient will need appropriate surveillance for these conditions as well. So what's the role of upper GI canthus? So once you're suspecting a hiatus hernia on upper GI endoscopy, which is an excellent mucosal investigation, you need more anatomical details, especially in cases where the patient has had previous operations, in case of redo surgeries. An upper GI contrast study is invaluable in documenting the actual anatomy of upper GI tract. So this is just an example of a hiatus hernia which presented to us. The whole of the stomach is in the chest. So, but sometimes there is a discordance between the esophageal, the upper GI endoscopy and the symptoms of the patient. In these cases, we need an objective evidence. For objective evidence, we go ahead and do the pH impedance monitoring, which is less likely needed in our setup, but only in cases where there is doubt about the diagnosis and you want to establish a definitive diagnosis. However, if the patient has presented with symptoms of dysphagia and we do not find any mechanical cause of obstruction, then we need to go ahead and do the panometry. So, the main question is, how do we choose the appropriate bariatric procedure for these patients? So, according to European Association for Laparoscopic Surgery, IFSO, and SAGE's guidelines, the most favored operation in these circumstances is a Roux-en-Y gastric bypass. So you have to understand the pathology here. The lower esophageal sphincter is not working. So whatever is there in the stomach is going to reflux. So if there is too much acid in the stomach, it's going to reflux. If there is too much bile in the stomach, it's also going to reflux. So how does Roux-en-Y gastric bypass help? So because the pouch is very small, so the total parietal cell mass is very low and the acid production is really low. Secondly, it is a low pressure system. There is no sphincter involved here, and the overall pressure inside the pouch remains low. Thirdly, it diverts the bile away from the stomach. So due to all of these characteristics, this is the favored procedure in case a patient has moderate to severe reflux or any complication thereof. So these are the specific indications of Roux-en-Y gastric bypass, that is severe GERD, type COD esophagitis, bad esophagus, peptic stricture, or type 2 to 4 paraesophageal hernia. So what's the role of sleeve in these cases? So sleeve can still be performed in a patient who has very minimal symptom but no hiatus hernia which needs a repair. The sleeve is not a good option because it is a very high pressure system. It is very narrow in caliber. There is a pylorus which provides resistance, and if there is any degree of angulation or narrowing at the incisura, it can further aggravate not only the reflux but also the risk of leakage. So mini gastric bypass, again, it's a low pressure system, and because of the length of the pouch, the bile is also diverted away from the stomach. However, there is always some degree of bile in the stomach. So if the lower esophageal sphincter is not working properly, the patient has severe reflux or a big hiatus hernia due to which the lower esophageal sphincter is disrupted, then this bile is going to reflux into the esophagus as well. So it's not about the procedure is fine, but it's just that the normal anatomy is not working properly, the lower esophageal sphincter is not working. So indications of concomitant repair. So any symptomatic hiatus hernia should be repaired at the time of bariatric surgery. If there is a clear migration of gastroesophageal junction into the chest, then it should be repaired because it precludes safe dissection or safe construction of the bariatric anatomy. However, or if there is any type 2 to 4 hernia, it should always be repaired. However, if there is a minimal anterior dimple, then it should be left alone. But you have to make sure that you reflect the gastroesophageal junction, fat pad, and expose the left crust to make sure that there is no hiatus hernia. In obese patient, I'll give you an example later on. This can be a little tricky because there is a lot of fat around that area and may be hiding a small hiatus hernia. So what should be the operative technique? So first of all, intraoperative assessment. So as you can see that this patient, this is not a bariatric patient. This patient has a relatively medium-sized hiatus hernia, and this patient has a giant hiatus hernia. Most of the stomach is in the chest. So these patients are not bariatric patients. However, let's come up to this example. You can see this dimple here anteriorly. It's a relatively large one, and there is gasophageal, there's a lot of fat around the gasophageal junction. This patient had an BMI of around 50, and apparently there is no hiatus hernia, but on reflection of the gasophageal junction, this is the margin of the crust, the left crust, and you can not see any esophagus below the crust. So you suspect a hiatus hernia. So on further dissection, you can see that there is a large defect, and after dissection, the gasophageal junction is now in the abdomen. So in these cases, you always reflect the gasophageal junction fat pad on the left crust and make sure that there is no hiatus hernia underlying a lot of fat in that area. So what are the components of hiatus hernia repair? So mainly there are three components. Number one, at least 2 to 3 centimeter of the esophagus and the gasophageal junction should be inside the abdomen. That's one. Number two, the repair of the hiatus itself. And number three, anti-reflux procedure, which in case of a bariatric surgery is mostly, in most cases, a Roux-en-Y gastric bypass. So again, coming back to the example of a giant hiatus hernia, you can see after mobilization, esophagus is comfortably lying in the abdomen, and there is a huge defect. So most commonly, posterior cruroplasty is recommended, but there is an extent to which you can do the posterior cruroplasty, because at some point you will see that the esophagus started sort of bending forward or kinking forward. This is called as speed bumping. So if there is a lot of speed bumping happening, then it can lead to post-operative dysphagia. So in that case, the remaining anterior defect, as you can see here, can be repaired with the help of a suture or two. But predominantly, the repair is posterior. And in such cases where there is a huge hiatus hernia, then you need to reinforce it with the help of an absorbable mesh. So unfortunately, the tailor-made meshes are not available in Pakistan, but you have to make sure that it has to be an absorbable mesh. Plus, it cannot be a circumferential mesh around the esophagus, because that's going to cause dysphagia and erosion into the esophagus. So what are the outcomes? So outcomes are very good and also depend not only on the repair, but also the choice of the bariatric procedure that you do. So for a sleeve, at least 2/3 of the patient, if they are combined with a hiatus hernia repair, at least 2/3 of the patient will be free of their symptom. However, because sleeve is itself a reflexogenic procedure, so 20% of the patients are going to develop a de novo reflux after sleeve. However, after Roux-en-Y gastric bypass, most of the patients, the results are very good. Up to 5-year trial and 5 meta-analyses have been done, and all of them show very good results, and reflux is cured in most of the patients. And there is minimal chances of de novo reflux. The data on hiatus hernia repair with mini gastric bypass is not very robust, so it is still an area of research. Okay. So post-operatively, if the patient has any residual symptoms, then or if there are recurrent symptoms, then they need to be screened with the help of an upper GI endoscopy. However, if the patient does not have any symptom, then the surveillance will depend on the type of the procedure. For example, after a sleeve gastrectomy, it is recommended for the patients to undergo a upper GI endoscopy every 3 to 5 years. Whereas in case of, for example, if there is an underlying esophageal condition such as a Barrett esophagus, then you follow the guidelines of that particular condition. Okay, so I'll summarize my talk into preoperative, procedure and postoperative. So preoperatively, the screening starts with the history and relevant investigation. In most cases, the first line is upper GI endoscopy. In case of any discordance between the history and the investigations and the examination finding, then you go ahead and do other investigations such as pH manometry. The procedure selection in most cases with moderate or significant reflux is going to be Roux-en-Y gastric bypass. However, you should not touch a minimal dimple or a minimal asymptomatic hiatus hernia in a bariatric patient. So the take-home message is either repair it properly with high dissection into the mediastinum 360 degree and do a proper repair or don't do anything. Don't do a half-hearted stitch anteriorly or posteriorly. That's not going to help. Post-operatively, if the patient remains asymptomatic, then you follow the guideline for that particular procedure or the underlying condition. But if they ever become symptomatic, then you have to investigate the patient either with upper GI endoscopy or with anatomical investigation such as a CT scan or a gastrograph in swallow. So in conclusion, hiatus hernia is not just simply a defect. It is the whole altered gastroesophageal anatomy as well as the resultant mucosal damage and the symptom that the patient has. And any treatment should be tailored depending on all of, should be tailored to all of these, keeping in mind. And this is the CVO.
Thank you, Usama. Wonderful presentation.